Hello and welcome to Sip of Wellness, the podcast where we dive headfirst into the awesome world of healthcare and wellness. Stick around as we chat about all sorts of things, one sip at a time, discovering all the facts that shape how we feel emotionally, mentally, and physically. We're diving into interviews with the experts, sharing facts that'll support you all the way, and questions that'll make you think. So grab your favorite drink, find a comfy spot, and let's gulp down some wisdom that'll support you in your journey to a more balanced and vibrant life. I'm Rima, and today we are honored to feature Dr. Alaa Younus. Dr. Alaa is a Canadian obstetrics and gynecology consultant with more than 20 years of experience in the field of obstetrics and gynecology. Dr. Alaa specializes in low and high risk pregnancy with recurrent miscarriages, and she works in everything related to gynecology and obstetric cases. Dr. Alaa will discuss and share her thoughts with us today about everything related to vaginal versus C-section deliveries. Dr. Alaa, welcome to the podcast.
Thank you very much, Rima, for this introduction.
Thank you.
Nice
We're happy to have you. Thank you.
Thank you very much.
Dr. Alaa, before we start, can you tell our viewers and our listeners a bit about your journey to where you've come right now, being one of the most distinguished consultants in the field of obstetrics and gynecology?
Thank you very much. I came from, originally I'm Iraqi.
Okay.
I graduated from Iraq and I finished my residency program in Iraq in obstetric and gynecology. And then I came to UAE and I continued the journey in obstetric in one of the most esteemed hospitals. It was Al Wasl Hospital that time.
Mm-hmm.
I worked in Al Wasl Hospital. Then I pursued my career in Canada. I worked for infertility branch in Canada. Then I came back again to UAE because I love to be in Dubai. Okay. And I don't know the next path where we'll be in life.
Okay. How have you seen like a difference in the trends in general? Because I believe 20 years ago, the scene related to obstetrics and gynecology is completely different from now.
Yeah, it is like the cesarean section rate is increasing dramatically. 20 years back, we will encourage, and the cesarean section was very low rather than this rate today. Mm-hmm. The rate now is around 30 to 35% of all deliveries. It might be higher in some countries and it might be lower in some countries, but this is in general, 30 to 35%. If we are encouraging only cesarean section rate or we are promoting cesarean, then the rate expected to be higher in the next decade to 70%, which is alarming figure when we think about the risks of repeated cesarean section. And that's why we are promoting vaginal birth rather than cesarean section. 20 years back, women, they tend to have more babies and they want more to go for vaginal delivery. And they are happy to have vaginal delivery pain. In contrary to now, the women, they are tending to choose the elective date of the cesarean because they don't want to go for vaginal delivery. They don't want to practice to have the pain related to vaginal delivery, which we have
it's more convenient overall.
Yeah, we have to sit with the mother and we will see what is her fears. Is it the fear from the vaginal birth itself, from the process? Is it the fear from the pain? Is it the fear that her further sexual function will be affected by vaginal birth? Is it the timing? Because sometimes women choose the birth plan according to her convenience, social problem. Or is it like those women that they had passed through the birth, vaginal birth, they experienced the vaginal birth, and they have a trauma. Could be psychological trauma from the vaginal birth, could be something else, physical trauma. So you have to sit with the mother, counsel her why she is choosing elective cesarean section rather go through the birth of vaginal birth. Yeah.
Dr. Alaa, what would you say are the benefits overall to vaginal birth as opposed to C-sections, like for the mother and for the baby?
Yeah, of course, for the mother, it will be a faster recovery than the cesarean section.
Okay.
The hospital stay, it will be less. The mother will recover completely after 6 weeks if the vaginal delivery was uncomplicated, no complication, no problem. So she will be completely recovered after 6 weeks. The passage of the baby through the birth canal, it will promote the respiration of the baby, that he would not be admitted to the neonatal care unit if he passes through the birth canal. Squeezing of the chest wall and the stress that the baby pass through the vaginal delivery makes the baby more liable to get the breathing well. They will not get admitted to the NICU because they have been through the stress of labor. On the other side, cesarean section. I'm not saying cesarean section rate is not an option. We have many patients that we recommend them not to go for vaginal delivery. We will go to this. But cesarean section rate, definitely the recovery, it will take longer. The pain that she will feel it after the scar in the uterus and the scar in the abdomen is longer than the cesarean, than the normal delivery. Recovery, it takes longer. It takes around 6 to 8 weeks to fully recover. And it is proven that babies delivered through section, they haven't passed through the stress of vaginal delivery, so they are more prone to get admitted to the neonatal care unit because of transient tachypnea of a newborn, the transition between intrauterine and extrauterine life. And that happen even at term. We are not speaking about preterm deliveries. Even at term, which is 39, 40 weeks of gestation, patient who is for elective cesarean section or they had an emergency, those babies, because of the transition between the intrauterine and extrauterine life, they are tend to have more admission to the NICU rather than babies who had got through vaginal delivery. Yeah.
So we can say that in general, it's healthier not just for the mother, also for the baby.
Yeah, it is.
Vaginal deliveries.
Yes, of course.
Okay.
The stress of labor, this makes the baby is more mature, and the lungs will be more liable to get the stress when he was born outside. Yeah.
Dr. Alaa, would you say there are instances where vaginal delivery is out of the question and you have to basically tell your patient that it's not possible to go for vaginal deliveries and you have to go for C-sections?
Yeah, of course. There is conditions that vaginal delivery is contraindicated for the safety of the mother and baby. Like a patient who had a placenta previa.
Okay.
Where the afterbirth of the baby is below the baby's head or below.
Okay.
And this is the risk of a placental separation and placental bleeding during labor is high. Okay. There is risk when the baby is a breech and it is term a breech or it is in a transverse lie. Other than the head, anything other than the head, it can carry a risk, whether the baby is a breech, whether the baby is a transverse. Twins, there is a high risk that even if they are both on the head, there is a high risk of cesarean section for the second twin. Okay. For extremely preterm baby who's in a breech presentation, for those who had a very high blood pressure and the baby in distress, and you have to save the baby and the mother's life. There is many situations that it can endanger the mother's and the baby's life, and cesarean section is the safer option rather than going for vaginal delivery. Cesarean section now, it is safer than when it is started. I'm not talking about my era, my generation. When we start, when I was trained and as a resident, cesarean section is safe because we have an antibiotic, we have the operating rooms that it is fully equipped and under sterilized condition. So it is safer, like when we are talking in the beginning of the last century, let us say.
It's been around for that long?
Yeah. Cesarean section, it has been around for that long, and we are doing this for many, many years. But it is now a safer option because we are having protocols, we are having antibiotic, we are having a thromboprophylaxis after cesarean sections. So it is a safer option in a lot of conditions in obstetric. But in cases of uncomplicated, normal mother, that she doesn't have any medical problem, the baby growth is fine, the baby is not very big baby, the baby is not very small baby, the head is down, why we should go for cesarean section?
Definitely.
I would go for vaginal delivery rather than cesarean.
And in these cases, if the mother really is afraid of natural delivery and she wants to go for a C-section because of convenience, as you mentioned, how would you counsel her? What would you say?
Well, I am facing such patients a lot in my clinic, and some of them I convince them to go for vaginal delivery, and thanks God they will be having successful vaginal delivery without any complication. And some of them, they are insisting on their decision. In that case, the mother had the right to choose the mode of delivery. And it is ethical that you should listen to the mother, because it is well documented in all the colleges that if the mother choose the cesarean section after the counseling, she had the right to choose.
Whatever the condition is?
You cannot deny. This is her choice. If you counsel her and she's still insisting on her choice of cesarean section, even without any complications, she is uncomplicated pregnancy, everything is okay, you can deliver normally, you feel that you can deliver, but the mother choose to do cesarean section, yes, this is her right, this is her body, this is her baby, and it is ethical to listen to her and respect her choice, accept her choice, and help her. You had counseled her, you had told her, you had advised her, but this is her choice.
Have you come across cases where the mother wanted one thing and the father wanted one thing? Because usually I hear about it a lot, when each one of them, for example, even in natural deliveries, when it comes to the pain management as well, you see one who wants one thing, the other who wants something else.
Many. We are facing every day this dilemma when the mother wants something, sometimes the father against it, especially epidural analgesia. This is what we are facing. Usually we have to listen to the mother because this is her body and this is her choice, and what she is feeling, actually, the father is not feeling it. The pain of labor, according every patient has different level of threshold of pain, and this is what I tell the woman. We cannot say that you can take. I told her, you can take epidural if you feel that you want it. If you feel that you can't take the pain and you don't want epidural, it's fine. So the pain threshold is different from one woman to another, from one subject to another, and there is nobody is the same pain threshold. So we should listen to the mother.
Always, mother knows best, from before delivery till after. Dr. Alaa, are there cases also where C-sections are contraindicated? Because we spoke about when vaginal deliveries are contraindicated. Are there cases when C-section is not the right choice or not the thing that they should go for?
Yeah, it is a difficult problem, a difficult question to tell you, because in obstetric, the moment it can change dramatically in 1 or 5 minutes. There is nothing like strict and hard rule. But if I feel that the baby is, yes, down in the vaginal canal and in the vagina and it's about to deliver and the mother is requesting for C-section, it will be more harmful for the baby and for the mother to deliver a C-section rather than to use instrumental delivery and try to deliver the baby vaginally.
Okay.
So only this situation where the baby is really in the
Already
birth
down,
canal down and it is really impacted when it is very difficult, and this is very difficult sometimes decision for the obstetrician to deliver. But if it is safer for the baby, yes, you can deliver vaginally with instrumental delivery rather than go for C-section and subject the baby for trauma and the mother for trauma and complication. Yeah.
Okay. How do you think it differs, by the way, the process leading to delivery if the patient is going for vaginal delivery versus if she's going for a C-section, like her birth plan in terms of her mentally and physically preparing for the delivery? Would you say it differs in any way or not at all?
Yeah, of course. It is a 9 month journey. The mother, she started to think about it from the beginning. I'm telling you that my patients, they started from 6-8 weeks, how I will deliver, how I will go for vaginal delivery. Is it painful? Then I will tell them, please calm down, enjoy your pregnancy, enjoy your journey. No need to think about it from early weeks of gestation. Just enjoy the pregnancy. But this is the important part. This is the confidence that we built with our patient during antenatal care. If she is confident that her obstetrician is doing the best for her, she will listen, and she will listen to the counseling that it's best for her to go for vaginal delivery or go for C-section. This is the confidence, and the conversation, it lasts. It is not over half an hour or 1 hour. It's about 9 months of a continuous care between the mother and the obstetrician.
Yeah, because the obstetrician shares the journey with the parents. It's not a one-time thing, as you mentioned. So they have to have trust in their decision and their counseling, basically, so that they can make the right choice.
Yeah, of course, yeah.
Yes. What about the cases of patients who were strictly against C-section? We know that nothing is planned. Like, you can plan as much as you want, but as you said, like, things change between 1 minute and the other on the day of the delivery.
Yes.
So what would you tell patients who were strictly against C-sections and had to go last minute into an emergency C-section?
This is what I tell my patient. There is nothing guaranteed. There is no 100% at all. In obstetric, there is no 100%. But we will do all our efforts to deliver vaginally. If things goes wrong, if the baby's heartbeat is not well, if you are not progressing well, and this can risk the baby and risk your health, then we will go for C-section. But for me, I will tell them, I will do all my efforts to deliver you vaginally. But there is nothing, no 100% guarantee. Yeah. And this is true. I cannot guarantee. Most of, like I have 6 deliveries last week.
Okay.
5 of them was vaginal delivery, 1 was cesarean section. It doesn't mean that I want to do this. That was a planned cesarean section, by the way, not an emergency.
Okay.
So it doesn't mean that I can guarantee for those vaginal delivery that I will deliver you vaginally. But I can do all my efforts to help you do vaginal delivery. Just listen to me. Trust me. Trust my decision. I will help you. I'm not going to take you for cesarean section emergency unless you are well informed about my decision. And usually the mother will be informed whatever we are taking, which decision, we have to be informing her. Yeah.
Especially that now the vaginal delivery, it's not like it used to. Like before, it was just like one position and the baby comes out. Now there's water birth. There are different delivery positions also, like whatever the mother is more comfortable with.
Yeah.
And also like the father is more involved in the natural delivery versus the C-section.
Yeah.
So how has this changed? Because I know like water birth is something relatively new. Has it changed?
It is not new. water birth, it has been documented, and water by itself, it can relieve the pain. For women and for mothers who like to have a natural birth without any medical intervention, not a medicated delivery. They don't want to have the pain relief through drugs or gases or epidural. They want the natural way of relieving the pain. Water birth is a good option, especially in a selected patient. Not all the patient you have to give a water birth. There is a selective criteria for water birth. And about the position, yes, there is many patients who opt not to have in a lying down position or lithotomy position. They have to be in a squatting position, in upright position. This can help also for the descent of the head, the natural process of birth without interference. And it is very good and useful positions. Yes, if the woman opt to, yes, it will be very good.
Amazing. We've seen a lot of changes anyways, like a lot of a lot of changes now in the field of pain management in general. Like a lot of things have changed than before. But do you think this plays a huge role in why people are going more towards C-sections rather than natural?
I think people, they are influenced a lot by the social media again.
Okay.
And once they, this is what I noticed from my patients, that they are influenced a lot about the social media. About
How so?
Why people, they are posting the normal delivery as it is painful process, it is tiring process, it will take time, you will be tired for 12 to 16 hours and it doesn't work, and this so they will be choosing the cesarean. You mentioned that the pain medication had improved. It should encourage us to go for vaginal delivery rather than cesarean section.
Exactly.
Because we have other modalities of pain management of during labor. Before we were using only medication that can be given intramuscular or IV or nitrous oxide. Then it started the epidural. Then sometimes we combined the spinal and epidural. Sometimes only spinal epidural. This is all can help the woman to relieve the pain during labor. All can facilitate dilatation of the cervix smoothly and descent of the head smoothly. I think advances in the medication, it should promote us to deliver vaginally. But women are now more convenient of something that it is planned.
Yeah.
Plan the date, plan the time. I don't want to go through this. I don't want to go with unexpected things. And the fear always from mothers who's giving birth for the first time from the primary gravida. They fear that to go into labor and then they will end up by cesarean section.
Okay.
And usually I told them, if we don't go through the experience, we cannot say that we will succeed.
Okay.
We have to go. We have to try the vaginal delivery. And
whatever happens, happens. Like, we'll take it from there.
Yeah, we will take it from there. And like, it will succeed in 80%, 90%, it will succeed. But if you just choose cesarean section because I'm afraid that I will go eventually for cesarean, then you are cutting the circuit very short, and you make the things like judged by. No, you're absolutely right. But it's just that from example, my circle of people, I know a lot of people who are afraid of the epidural. They're afraid of, for example, the concept of sexual intercourse after delivery. They're afraid of tears. Like, these are more or less the most challenges in the women's in any mother's
from her point of view. So what would you say about like these three concepts, like sexual intercourse, tears, and epidurals? We already covered epidurals a bit.
No problem. See, let us be scientific and not biased.
Okay.
We know that vaginal delivery, it can cause sexual dysfunction, especially if it is repeated, because of nerve denervation, of the pelvic nerve denervation, if it is vaginal delivery. Cesarean section, yes, it can prevent this nerve denervation, pelvic nerve denervation, and it can restore the sexual function, and it will not affect the sexual function. This is regarding the sexual function.
Okay.
Regarding the epidural is very safe way of pain relief, especially if it is given by an experienced anesthetist. And we haven't encountered, in all my career, I have seen only one complicated case.
That's very minor.
In 23 years of obstetric, I have seen only one case of epidural complication, which makes that the things is very minor.
Okay.
The other things regarding the tear and episiotomy. Tears might happen if we don't give episiotomy. Now the choice whether we can give a sharp, clean cut to the perineum and save the perineum from tears, and then suturing of this clean cut, it will be much convenient and easier. Healing is better than multiple tears. Some of the women, to be frank, some of the women that they don't want even a cut or episiotomy, they will end up with multiple tears. It makes it difficult for her more than the obstetrician. Obstetrician will just stitch the tear, but tears in multiple locations of the vagina, more painful for her. Restoring sexual function will be difficult for her after 6 weeks after delivery. Tears might extend to the rectum. It might cause a third-degree perineal tear. If we have a third-degree perineal tear extending to the anus and to the rectum, then this patient will not deliver at all vaginally. We have to consider cesarean section for a patient who had third-degree perineal tear. So I would educate the woman, returning back to the first block, education of the woman that small episiotomy is better than giving multiple tears.
Definitely.
Restoring sexual function, we will turn to this again because many women, they are not happy after vaginal delivery of restoring her sexual function. Actually, it is not that bad or that obvious for a woman. It depends on your obstetrician, how she will stitch it in a nice, neat way, how restoration of the layers of the episiotomy had been done, then it will be fine. You will not feel any differences. Yeah.
So they all can be avoided if someone makes an informed decision before they go into a vaginal delivery. If they want to go for an episiotomy, and if they want to do all of these preventive measures, because this decision alone can help with the restoration of the sexual function, can help with the shape, can help avoid tears, at least tears that can be eventually like properly sutured and that end up looking nice, you know?
Yeah.
So it's all about making an informed decision.
Yeah, and all about education.
Yes.
Education starts from the first maybe 12 weeks.
Okay.
As I told you, patient, they will come from 5 to 6 weeks, they are afraid from vaginal delivery. Why you are afraid from vaginal delivery? Enjoy your pregnancy. We will discuss these things later on. Don't stress yourself with vaginal delivery from 6-8 weeks.
Exactly. When do you start the education? At 12 weeks? Or is it something for very, very advanced for later on?
It is a continuous educational process, but I would never stress the woman with a lot of information in the beginning of her pregnancy. I would like to enjoy her journey, not to be stressed out, because stress can affect her baby itself. So I don't discuss episiotomy tears earlier in the pregnancy, maybe at 32 weeks of onward.
Makes sense.
Yeah.
Dr. Alaa, you specialize in low and high risk pregnancies. Does the difference between low and high risk actually affect the eventual delivery method or the delivery way, or it doesn't really have an effect on?
Of course, we have a lot of high risk patient with repeated cesarean section. Like I have a patient, the previous 5 cesarean section plus tummy tuck. And that was her 6th cesarean section. And she's opting for the 7th also.
Okay.
So we have a lot of repeated cesarean sections, a patient who had hypertension, diabetes, a patient who had intracranial hemorrhage, patient who had clipping of the some of the vessels, a patient with heart disease.
Okay.
These are going for, yes, we would prefer elective cesarean section.
Okay.
Patient who has gestational could be type 1 or type 2 diabetes, or gestational diabetes with very high insulin dose, very big baby, macrosomia. Those we recommend better to go for vaginal for cesarean section rather than vaginal delivery. And then there will be trauma to the baby and to the mother.
Yeah. But in all other cases, if it's a low-risk pregnancy, you definitely mostly would suggest or would highlight the importance of vaginal delivery as opposed to...
Yeah, even in diabetic patient who is on insulin, still I will do and recommend vaginal delivery, and succeeded in many of those with vaginal delivery. Even in hypertensive patient, I didn't say strictly, but even in hypertensive, we can achieve a vaginal delivery. But there are certain cases that the blood pressure is very high. She had intertoxemia of a pregnancy. There is a risk that the baby will be delivered with abnormality because of the heartbeat, then we will recommend. But otherwise, low-risk pregnancy, I will counsel her thoroughly. And I will spend all my effort to encourage her for vaginal delivery. But by the end of the day, as I told you,
up to her.
It's
their
the patient
decision.
choice. And,
yes. Dr. Alaa, we're seeing, as you mentioned in the beginning, a trend of people moving towards elective C-sections now. If we were to hopefully encourage more patients to reconsider vaginal birth as opposed to C-sections, if we were to segment them between emotional, mental, physical benefits for both the mother and the child, what do you think we can highlight if we say emotionally? Is there a difference?
Emotionally, there is a difference also because passing through the process of labor, the pain that she is getting it even before we give her the pain management. The process itself of labor that takes hours makes her appreciate this baby had been delivered after such a long period. But I'm happy that I'm carrying now my baby after that much struggle I passed through. So emotionally, yes, there is a difference. Physically, yes, there is a difference.
Definitely,
for both the baby, as we said, and the mother. And what was the third point?
Mentally.
Mentally, I believe all the women the moment they enjoy the first moment of deliveries, whether by C-section and by normal delivery. All of them, they are waiting for this moment of listening to the first cry of the baby and having a skin-to-skin contact after the baby born. I think there is no difference a lot between C-section and vaginal delivery. Especially we are adopting that we do skin-to-skin contact immediately after delivery.
In both cases, in both options?
In both cases, we opt to do skin-to-skin. In both cases, we do delayed cord clamping.
Yes.
Only in special circumstances where the baby in distress and we need neonatal care that we have to do immediate cord clamping and get the baby to the neonatologist. But in all cases, we do a skin-to-skin contact, early breastfeeding, even when she is in the operating theater, if it is cesarean section, when she is in the delivery room, if it is normal delivery,
So in the delivery room, there is no actual difference after, let's say, after the baby's out. In both cases, there isn't any difference after the baby's out within the delivery room. So the baby will still have skin-to-skin contact immediately. But I think the main difference would be the mother's readiness to, because I know that in C-sections, she will stay under, like, or she will go to sleep again for a while, or no, doesn't really.
No, actually, no. This is the
misconceptions for women.
No, this is a misconception because now with the modern anesthesia, and since a long time we are adopting spinal anesthesia, so the mother is awake during the whole cesarean section, and she will listen to the babies, and she will see the baby when born, when he is born or she's born. Okay. So immediately in the operating theater, we give the baby to the mother with a skin-to-skin contact and trying to feed the baby while she is on operating theater. She will not be drowsy or sleeping like before. 20 years back, 23, when I was a resident, we were using more general anesthesia. And then the mother will be sleepy after the general anesthesia. She will be separated from the baby for a while till she will recover completely. But now we hardly use general anesthesia, hardly. Unless certain cases, only certain cases. There is a place for general anesthesia in obstetric in cases that very high blood pressure and we need to quickly take the baby out to reduce the blood pressure. In cases of very emergency that we cannot spend time putting the spinal anesthesia because if the baby is severely in distress in case of obstetric hemorrhage like placental separation or abruptio placentae and you need to take this baby out, there is a place of general anesthesia. But mostly we are doing spinal anesthesia. So the mother is completely, fully awake. The father is on her side, supporting her.
It's such a magical journey. Pregnancy, delivery, everything. Like every woman to me is a superhero for her. Every woman and the mother is a superhero.
Yeah.
But if you were to say one last thing to couples who are expecting their first baby, to women who have a more concerned outlook to delivery in general, what would you tell them? Like to kind of ease their mind, ease their thoughts?
Enjoy your pregnancy. Enjoy your journey. Don't stress yourself with a lot of thoughts and a lot of video clips. Leave the things to nature. Nature is usually...
will take its course.
Believe in your obstetrician. See what she will tell you. Because the obstetrician, we didn't reach to this level by reading for 1 or 2 years. We have the experience of many, many years. It is not contraindicated or it is not allowed to go for section, but it's better to go for vaginal delivery because it's still cesarean section is safe option when we have the baby in danger or the mother in danger.
Okay.
So
plan B instead of plan A.
So just I will tell her enjoy, leave the nature to take it out, not to stress yourself with a lot of thoughts about what will happen. Because what will happen, it will happen. It's why
you don't really have control much over it. Thank you so much for this very interesting episode, Dr. Alaa.
Thank you.
As you said, like pregnancy again is an amazing journey, and eventually, once the mother sees her baby, like she will not think about everything that happened. For everyone who enjoyed this episode, you can find Dr. Alaa Younus in Faqih University Hospital. Thank you again so much for being here.
Thank you very
We're
much for
honored to have
having
you.
me. I would like to thank SalSafe for this opportunity to speak to many pregnant ladies who is now might watch us, and encourage them also to do one more step in the vaginal delivery.
Okay.
Please go and do stem cell collection, because this is life-saving.
Definitely. Thank you so much, Dr. Alaa. If you like this episode, you can put thumbs up on this podcast and follow us on YouTube. Thank you so much.